I think it's really exciting that we're hearing new data in perhaps the frontline setting for metastatic clear cell RCC. And so that brings us to updates that we've had for regimens that we've been using for years now, both with Checkmate 90R updates, which we'll hear about, and Checkmate 214 updates. I would love to hear what's your approach to a new diagnosis of clear cell metastatic RCC.
Please, oh, sure. Thank you very much. So we've been having this debate going on whether IMDC should be ruling the selection for first-line treatment or not. I do favor more how the patient is presenting, whether they have any symptoms or not, or whether I need to look for a kind of rapid response or not. In full honesty, if I want to pick one regimen, I personally tend to do the nivo-EP combination more often because I like having cabozantinib in my back pocket once the disease progression presents. Nevertheless, I don't have data suggesting that if you want to do nivo-cabo or len-pembro or whichever combination you prefer, that you should be not doing it. It's more of a personal preference and something we learned since last year with the nivo-EP data that Dr. Tarnier gives the update is that even though like the initial trial was not designed to look for the signal in the favorable risk population, like in the long term, we're seeing that these curves are starting to separate, and this regimen, I think it's also appropriate for favorable risk patients.
What does the rest of the group think about IO for favorable risk patients?
You were going to go next, Ben.
Someone was asking me about this earlier, like what's my approach to favorable risk patients? And the most succinct answer I could give is haphazard, because I find that this population of patients is particularly challenging to treat if I'm trying to find the optimal therapy for that specific patient, because it's so heterogeneous, right? We've got patients in there that do fine with surveillance. We have patients that really could benefit from a cure because even though they have favorable risk disease, they're still pretty young and their cancer does grow with a faster pace than you would predict by just the IMDC score. So it's a really tricky population to benefit. I mean, like to identify the optimal therapy for. And because this group of patients does so well for so long, largely regardless of what you treat them with, it does make me concerned about long-term toxicities that can happen in some patients with ipi-nivo. Like I'm always enticed by this carrot that's dangling in front of me with ipi-nivo if I can cure people. But I've also seen patients that I've treated that now are on dialysis, or now they have type 1 diabetes, and if your patient population is likely going to live for a really long time, it gets really tricky to decide like how do I treat them. So I don't know. Like so many factors come into it that I can't say in honesty that I have like a way of treating this complex patient population. But certainly the data that Nazir presented with the really long follow-up in the favorable risk population has changed my paradigm a little bit so that I like consider and entertain ipi-nivo along with a myriad of other options for this group as well. I don't know, I find them particularly challenging. How about the rest of you?
Not so much. I mean, it's a discussion with the patients, so I agree that when you add CTLA-4, you're twice as likely to have risk of severe tox than if you just do PD-1. But if the patient's goal is, as Ben said, remission or potentially cure, and they understand the risks and they're willing to accept them, then we've been treating people with nivo-ipi for years now. Mm-hmm. We never followed the guidelines. We weren't forced to follow the guidelines, and now the guidelines have expanded, as Regina was saying, so that you can give nivo-ipi in that setting. There obviously are trade-offs, but to me, it's not just the long-term benefit; it's the chance of being long-term and off drug, which is what patients want the most. And what we call the treatment-free survival period is meaningful. It's hard to compare across trials. It would be nice to do a treatment-free survival analysis in Laurence's COSMIC trial, as I'm pretty sure what that would show, but we'd have to be able to do the analysis. But the point of the story is it's not just long-term benefit off drug, But you have to educate your patients. Your patients have to understand what they're signing up for.
Absolutely.
Yeah, I definitely agree with that, particularly in this patient population. I guess what makes it somewhat challenging for me is, I can also achieve a treatment-free interval oftentimes by doing intermittent TKI therapy for some of them. So, anyway, I feel like there's lots of right answers for this patient population. And I think probably the best approach is, as you described, like you really need to have a good discussion with the patient about what are they wanting to accomplish and what are they willing to accept.
Yeah, their goals,
Yeah.
essentially.
Absolutely. And so when it comes to deciding on frontline IO-TKI, does anybody have a preference? Does the second line choice influence what you're going to give in the frontline setting?
I guess for me, no. The way, fortunately, kidney cancer is becoming more complex because we're getting better treatments. But the guiding principle that I usually follow is, let's decide the best treatment today, because the studies do repeatedly show that the greatest impact that you can have in a patient's, cancer experiences with that first treatment. And then the second treatment has a significant impact, but typically less so than the first. So I usually don't decide on first-line treatment based on let's make sure second, third-line options are optimized. Like, let's figure out what's best for this line of therapy for the patient.
And so along those lines, do you have a preference for IO-TKI? Is it just, do you get used to one, know how to manage the dose reductions and toxicities and stick to that?
Yeah, oftentimes I do, I guess for full disclosure, use a lot of ipi-nivo as my first-line therapy. So that sort of allows, in the context of this question anyway, whatever TKI I want for the next line therapy, second line and beyond. But for those patients that do have very symptomatic disease or particularly aggressive disease, those are the patients I tend to prioritize for a TKI-IO-based combination. And from my experience in treating patients with these therapies, and at least based on the published data from CLEAR and 9ER, et cetera, they all seem to perform very well in what I'm hoping to accomplish with them, which is get good short-term disease control, because that's really what I'm worried about at that moment for that patient, is reversing their hypoxia or their progressing fulminant liver injury or something. So for me, the incorporation of a TKI is works really well, and that's what it's needed. When I talk to people, at least in my regional community, that don't see, like a community oncologist doesn't see a lot of kidney cancer typically, the advice I usually tell them is get familiar with one of these combinations and use that, because I think that's going to be much more successful for them than trying to say, like, for this patient I do this combination, for that patient I do that combination.
Right, that's very true. And does anybody else have any input?
In particular, I do favor probably nivolumab with cabozantinib because of the 40 milligram dosing we use. I think quality of life, and the data from 9ER shows us that the quality of life in these patients actually do get better. So that's why I tend to favor it, but it's like a personal preference. I wouldn't be against somebody starting with Lem-Pembro or Axi-Pembro.